Good morning, everyone. My name is Ali Khan. I'm a member of the Retina Service at Wills Eye Hospital, and I'm happy to present to you this morning regarding outcomes of epiretinal membrane surgery and OCT biomarkers of visual acuity. I have no financial disclosures. And the objectives today are to discuss an OCT-based criteria to grade and characterize epiretinal membranes and identify OCT-based biomarkers of visual outcomes in eyes undergoing epiretinal membrane surgery. So as we all know, the most common type of fibrovascular proliferation at the vitreoretinal interface is an epiretinal membrane. The pathophysiology is still not completely understood, but may involve hyalocyte proliferation in the setting of an anomalous posterior vitreous detachment. Vitrectomy and membrane peeling remains the standard of care for visually significant epiretinal membranes. However, visual recovery can be variable, depending person to person and from eye to eye. Here's an example of a clear epiretinal membrane on a fundus photograph with distortion of the foveal anatomy and clear retinal striae. We know from clinical practice that all epiretinal membranes are not created equal. Some might be mild with preservation of the foveal depression, while others might be more severe with other findings such as cystic intraretinal changes. So what do we consider when we consider surgery? Visual acuity. In the United States, the 2040 line on the Snellen chart is often used as a standard bearer. The imaging, how does the morphology truly look? And symptoms, particularly metaphorphopsia, is that a prominent part of the chief complaint? Ultimately, when deciding to do surgery, it would be beneficial to have a grading scheme to give a better idea prognostically on how a patient may do post-ERM surgery. In 2017, Govetto et al., including a group out of UCLA, described an SD-OCT-based ERM grading scheme, and this is easily completed in the office with a standard OCT and does not require any additional software or post-image processing. The grading scheme is as follows. Stage 1 is described as an ERM with preservation of the foveal depression, while stage 2, there's loss of the foveal depression. Stage 3 and stage 4 are defined by what we call an ectopic interfoveal layer, which is denoted by the white arrows. In stage 3, there is an ectopic interfoveal layer, or EIFL, but all retinal layers are still easily identifiable. On stage 4, there's an EIFL, but the retinal layers are no longer easily identifiable. There are additional biomarkers, particularly inner microcystoid changes, which are cystic changes in the inner retina, as well as ellipsoid zone disruption, which we're more familiar with. So we looked at retrospectively outcomes of 322 eyes undergoing idiopathic epiretinal membrane surgery at Wills Eye Hospital. We had very strict inclusion and exclusion criteria, so any concurrent retinal or macular disease, including other conditions such as glaucoma or corneal disease, were excluded, and the minimum follow-up was 6 months. We looked at OCT biomarkers in particular to assess if they could predict visual outcomes post-surgery. Here is a video of a standard epiretinal membrane surgery at our institution. A vitrectomy is completed, followed by installation of dilute indocyanine green, or ICG. ICG is quickly irrigated out, and you can see very nicely some negative stain from the epiretinal membrane, but also some nice green stain from the internal limiting membrane. Using 23, 25, or 27 gauge island forceps, the internal limiting membrane and ERM are peeled in a broad-based fashion, not necessarily fully arcade to arcade, but as broad as we think is necessary, and in as little of a traumatic fashion as possible. We peel the membranes off, hopefully in one sheet, as shown here. So we looked at outcomes based upon the ERM stage as well as the overall cohort. Preoperatively, we found that higher ERM stages were associated with worse visual acuity. The overall visual acuity at baseline was 20/60, which improved statistically significant fashion to 20/40 at final follow-up. We noticed that the greatest improvement in vision was noted in stage 3 and stage 4 eyes, which makes sense, as stage 1 and stage 2 may have had a ceiling effect on their visual acuity. While stage 1 did not have a significant improvement in visual acuity, this might be underestimating the improvement gained in symptoms such as metamorphopsia, which were not objectively assessed. We looked in a multivariate analysis of OCT features that were predictive of visual acuity at 6 months and at final follow-up. We found that inner microcystoid changes and ellipsoid zone disruption present at postoperative month 3 were associated with worse vision at 6 months and at final follow-up. So again, these are postoperative presence of these biomarkers, but they were significantly associated in multivariate analysis for both 6 months and at final follow-up. So while the ERM grade alone did not predict visual outcomes, these two OCT biomarkers did seem to do so. Here are some representative examples of stage 1, 2, 3, and 4 ERMs preoperatively and postoperatively with significant improvement in the foveal contour and visual acuity. We assessed the ability to achieve 20/40 vision or better. We found that ultimately greater than 80% of eyes in stage 1 and 2 achieved 20/40 vision or better, compared to 70% in stage 3 and under 50% in stage 4. So while we did notice a significant improvement in vision in stage 3 and 4 ERMs, the ultimate ability to achieve 20/40 vision was still higher in eyes with stage 1 and stage 2, which brings up the concept of surgical timing. Should we really wait until stage 2 or should we really wait until stage 3 or stage 4 if ultimately they're less able to achieve 20/40 vision? We did an initial analysis in eyes with concurrent glaucoma. The Govetto et al. Group had noted in a previous study that inner microcystoid changes were more common in eyes with glaucoma than in eyes without. We compared 114 eyes with glaucoma and ERM to an age, gender, and baseline vision match controlled group of 139 eyes with idiopathic epiretinal membrane. While baseline visual acuity was similar between groups, eyes with glaucoma did have worse final visual acuity. And interestingly, the presence of inner microcystoid changes was significantly higher preoperatively and postoperatively. So why would inner microcystic changes be associated with worse visual acuity? We think this might be closely related to Mueller cell viability. The internuclear layer contains structures that are crucial in maintaining retinal homeostasis, including the body of Mueller cells, and tractional forces from the epiretinal membrane may be further stressing in Mueller cells. This may be especially important in surgical decision-making, where stripping of the internal limbing membrane may also be detrimental to Mueller cells. So potentially interesting topic to look into and further study. So some take-home points. In the described OCT grading scheme, higher ERM stages were associated with worse visual acuity. At the preoperative visit, across all eyes, visual acuity improved after vitrectomy membrane peeling. However, eyes with stage 1 and stage 2 characteristics were more likely to achieve 20/40 vision at final follow-up. Inner microcystoid changes and ellipsoid zone disruption on postoperative month 3 OCT scans were negatively associated with later time points in terms of 6 months and final visual acuity. I'd like to thank our research team, particularly Razieh and Atta, our research fellows, and thank you for the opportunity to present to you this morning.